Aguirre. And so there will be a slide at that point that says, San Diego, Marshall Lewis, Alfredo Aguirre, and so that's when Darcy's going to switch the mouse over to them. Okay? And you guys are just going to run it straight through to the end. Okay? At that point, at the end of yours, I'm going to ask Barbara if she has any questions for you all. She's going to ask you a few questions. And then I'm going to say, great, thank you all, everyone. And we're now going to turn to audience questions. Before we do that, do you have, Barbara, do you have any questions for the panel of our presenters? And so that's when she's going to ask both Santa Clara and San Diego together a couple of questions. Then we're going to turn to the audience questions. Does that make sense?
Yes.
Yeah.
I'm going to be fielding all I'm going to be fielding all the written questions. It'll all be written, so there won't be any people calling in. And I'll just read it out. If it's obviously directed at someone, I'll make that clear. And then when we run out of time, I'm going to say, thank you all, we're out of time, and do the closing. Okay? And that's everything. And I see that we're at 12 o'clock, so we should probably switch over. Does anybody have any last-minute questions before we get started?
Not a last-minute question, but a last-minute comment, and that is you should plan to mute when you're not actually presenting.
And I can do that for us if you guys, well, we would want you to be able to chime in, so you can mute yourselves, I guess.
Right, but I'm just thinking that while we've been doing this, I've been hearing somebody's keyboard clicking, and so we don't want that to happen during the presentation.
Mm-hmm.
That was
I
me.
figured it out.
Don't worry.
Great. Okay, good. And I guess the only other thing is just remember that there is that delay with the mouse. So once the mouse is transferred to you, just use your mouse to click with the cursor once on the screen, and then trust that the arrows are going to work. There may be a delay. If there's a problem, just backtrack, but know that there may be a bit of a delay. So don't start hitting it frantically. Okay.
And Matt, I'm gonna press *1.
Give me the controls now, since I'm going to go first.
You've got them, Barbara. You should be able to click on the screen. Yep, we see you moving. And I'm going to press *1, which will open up our audio, and then Matt is going to begin our recording as well. So here we go, folks.
Thank you all so much. Okay. Good afternoon, everyone. On behalf of the California Institute for Mental Health, in collaboration with the Alcohol and Drug Policy Institute and the Integrated Behavioral Health Project, we would like to welcome you to the third of a 6-part webinar series, Integrating Primary Care, Mental Health, and Substance Use Services. The goal of this webinar series is to provide information on critical policy, design, financing, and practice issues related to integrated care from the California and national perspective. The webinars cover best practices and emerging practices in the field with presentations from state and national advocates, researchers, and practitioners. These webinars are free and open to all and are held from 12 to 1:30 p.m. on the dates indicated in the schedule, which is posted on the CIMH website. To view the schedule or to register for future webinars, please go to the CIMH online learning link on the CIMH website. Please note that you must register online for each webinar you wish to attend. The webinars are being recorded and are posted on the CIMH Integration Initiative's webpage following each event. Please note that the first 2 webinars in this series are now available online, and today's will be posted within a few days. I will cover the same information again at the end of this presentation. Again, good afternoon. My name is Lori Alexander. I am a behavioral health consultant with CIMH and the facilitator of today's webinar. I'm delighted to introduce our outstanding panel of presenters for today. First, we're going to be hearing from Barbara Maurer. Barbara Maurer, MSW CMC, is a managing consultant for MCPP Healthcare Consulting in Seattle, Washington. She has 20 years of consulting experience focused on strategic planning, program design, performance management, and quality management processes. Ms. Maurer is active nationally in writing, training, and consulting on ways to better integrate primary health care services with mental health and substance abuse services. And she serves as senior consultant for the National Council for Community Behavioral Health Care on this subject. Prior to her consulting practice, Ms. Maurer was a senior administrator at Group Health Cooperative of Puget Sound and headed the Public Mental Health, Substance Abuse, Developmental Disability System for King County, serving the greater Seattle area. After Ms. Maurer, we'll be hearing from Tiffany Ho and Bruce Copley from Santa Clara. Tiffany Ho, MD, has served as the Medical Director and an Executive Manager of the Santa Clara County Department of Mental Health for the past 7 years. She is co-chair of the Medical Services Committee of the California Mental Health Directors Association. Previously, Dr. Ho worked on health policies for Congressman Pete Stark on the Ways and Means Committee. She was also a senior policy advisor at SAMHSA, the Substance Abuse and Mental Health Services Administration, and was one of the founders of NAPIMA, the National Asian Americans and Pacific Islanders Mental Health Association. Bruce Copley, MA, has been the Deputy Director of the Santa Clara County Mental Health Department for 8 years. With the inception of the Mental Health Services Act, he has been actively involved in the development of innovative new services, including a residential criminal justice program, aftercare services for the juvenile justice population, a robust consumer and peer counseling program, and a redesign of the adult and older adult system of care based on the philosophy of wellness and recovery. Most recently, he has initiated a redesign of the family and children system of care, grounded in the understanding of how developmental delays and trauma affect the well-being of children and youth. Prior to his tenure with the Mental Health Department, he was the Deputy Director of the Santa Clara County Department of Alcohol and Drug Services for 14 years. Following the Santa Clara folks, we'll be hearing from Marshall Lewis and Alfredo Aguirre from San Diego. Marshall Lewis, MD, DFA, PA, is the Clinical Director for Behavioral Health Services for the County of San Diego's Health and Human Services Agency. He is also a Clinical Professor of Psychiatry at UCSD School of Medicine. Dr. Lewis received his BA at Yale University, his MD at Vanderbilt School of Medicine, and specialty training at Harvard Medical School, where he remained on faculty for a number of years. His 30 years of professional experience includes private practice, work in the for-profit arena, and service in the public sector. Prior to his work in San Diego, he was the medical director of Stanislaus County Behavioral Health Services for 11 years. Alfredo Aguirre, LCSW, is the president of the California Mental Health Directors Association, and he serves as co-chair of the Ethnic Services Committee. Most recently, he was appointed to be a member of the Alumni Network Steering Committee for the Child, Adolescent, and Family branch of the Center for Mental Health Services under SAMHSA. In 1999, Mr. Aguirre was hired as the Children's Mental Health Director for San Diego County. In 2004, Mr. Aguirre was hired as the Acting Older Adult Mental Health Director while maintaining the Children's Director. Over the last 6 years, Mr. Aguirre has led the effort to transform San Diego County's older adult mental health services, advancing a biopsychosocial rehabilitation model based on recovery principles. So many thanks to our distinguished presenters for being with us today. Before I turn things over to our first presenter, a brief word on how today's webinar is structured. Ms. Maurer will present an overview on partnerships. Then we'll hear from Tiffany Ho and Bruce Coakley from Santa Clara about their integration work. Next, we'll hear from Marshall Lewis and Alfredo Aguirre from San Diego about their integration work. Ms. Maurer will do brief question and answer sessions with each site, and then finally we'll have about 20 minutes for audience questions. Due to the limited time available and the large number of audience members, we will only take written questions for the presenters. To send in a written question at any point during the webinar, simply type your question and click Submit in the dialog box. All questions will be held until the end of the speaker's presentation. We've had a wonderful response to this webinar with well over 200 participants signing up, so we apologize that we may not be able to get to all of your questions during the webinar. Following this presentation, we will create an FAQ bank on the CIMH website to address as many of your questions as possible. So with all that housekeeping out of the way, I wanted to again thank you so much for joining us today, and we will now begin our presentation on creating partnerships that support integrated care. Ms. Maurer, I will turn the floor over to you.
Thanks very much, Lori. I appreciate the opportunity to participate in today's webinar with this distinguished group of individuals. And we're going to be talking about partnerships. What I plan to do is do just a brief overview of healthcare reform as it relates to partnerships. And then I will be talking about some structural models for integrated care. I am finding, I'm going to speak to one of the organizers here, that I am not getting movement on the slides, however. So we may need to do a little troubleshooting as we go along. Okay, there we go. The first thing I want to cover in talking a bit about the healthcare reform background is to remind you that there are three key things going on in healthcare reform: universal coverage and parity, patient-centered medical homes, and accountable care organizations as a part of payment reform. The insurance coverage piece we discussed in the webinar on the 6th of May, and we found that we don't really need to go into that in detail except to remind you that there will be an expansion in the Medicaid population of about 30%, with individuals who are single adults under the 133% of poverty line being able to apply for and receive Medicaid coverage without having to pursue disability status. The patient-centered medical home is the next piece that we have covered in the presentation on 5-6. And in the patient-centered medical home, there is the opportunity to work collaboratively with primary care partners to bring integrated care into their settings and to bring primary care into mental health and substance use settings. So both of these pieces were covered in pretty good detail, and I would refer you to the last webinar. What we did not talk about in detail in the last webinar are some of the administrative and payment changes that are envisioned. And what you will see here is the one of the key pieces being the idea of the accountable care organization. The accountable care organization is something that is called for in the legislation. It's intended to be at least one hospital, a minimum of 50 physicians, both primary care and specialists, and it's a group of people who commit to be in business for at least 3 to 5 years, serving at least 5,000 patients. Now, I am reading to you from a slide that has not yet come up onto the screen. Let me see if I can get it there for you. There we are. We have the accountable care organization, and the intent of accountable care organizations are to address pre-established quality goals, have mechanisms for receiving incentive payments, and be able to bundle and pay providers in differential methods. You'll see here that in Medicare, they will begin to respond to cost savings and bonusing in ACOs in the year 2012. There are also several Medicaid demonstration projects that have to do with paying bundled payments, making global capitated payments, and allowing medical providers to share in cost savings as a part of being in an accountable care organization. Why is that relevant to you as mental health and substance use providers? It's because we need to assure that if we're going to have bi-directional medical homes, that mental health and substance use providers become a part of the ACOs and have the ability to both obtain bonus sharing in terms of the reduction in overall healthcare expenses, as well as achieving quality goals. The accountable care organizations are really a vertical organizational system and will be set up with separate legal ownership and governance structures. You need to be thinking about the accountable care organizations that are being developed in your communities. We know there are conversations going on in California right now about creating accountable care organizations. And in many ways, you can think of these as being akin to the organized delivery systems that have been discussed as a part of the waiver. The new financing models that we are talking about are related then to this particular idea of accountable care organizations and would allow for primary care, patient-centered medical homes to receive a monthly case rate as a part of delivering chronic care and preventive services to a population. They would also bill for fee-for-service under the normal fee-for-service structures that are in place, and they would be able to share in the bonusing. So when you think about future financing methods, think about that three-layered model as the future financing world, and that becomes important when you think about the sustainability of partnerships. In terms of financing integrated care, one of the ideas that we have put on the table is to build on the California IPI initiative framework of mild, moderate, serious, and severe levels of care and look to the general health care system to fund mental health and substance use services for individuals who receive mild and moderate levels of care in primary care settings. What we know from the research is that the cost benefit will be on the healthcare side, and so we're proposing that that service should also be paid for on the healthcare side, and one way to think about paying it is incorporating it into the wraparound case rate for medical homes. Then the specialty system would continue to be funded to provide mental health and substance use services for the serious and severe levels of care and partner with primary care organizations to provide primary care in those settings. And again, we discussed that concept at some length in the webinar on 5-6. Moving ahead to aligning with healthcare reform in California, we know that the waiver discussion has focused on both improving quality and addressing total health care expenses. And we know that there's a focus in the waiver discussion on serving several subsets of the Medi-Cal population, individuals with special health care needs, children with special health care needs, dual eligible beneficiaries, adults with severe mental illness, and seniors and persons with disabilities, as well as children and family in rural counties that are currently not part of the managed care structure. The idea is to bring all these populations into organized systems of care to achieve these aims and assure that people have access to patient-centered medical homes. The structural models for integrated care then that could begin to support these kinds of alignments, and I want to stop and apologize to our listeners because there's a technical issue that we're dealing with here about being able to advance the slides, and they are going quite stubbornly and slowly, as you can see, but I'm trying to continue to use my allotted time wisely here while getting the slides to catch up. Hopefully. I think somebody else must be, Darcy, you may want to check to see. I can see your mouse moving on the screen, which makes me wonder if that's one of the reasons that I have a problem in advancing the slides. So here's the slide about the waiver and the focus on the 4 populations. You'll see here that one of the reasons why the waiver is under discussion is because 10% of Medi-Cal beneficiaries account for 74% of the total program costs, and in a fee-for-service system, they really aren't receiving coordinated care. So let's move ahead to partnerships and discuss the several models of partnerships. We'll look at three broad approaches: a fully integrated co-located care model that's provided by a single organization, a partnership model in which care is shared across two different organizations versus via co-located staff, and a facilitated referral approach in which a site helps clients coordinate care occurring at multiple different clinics or sites. And you're going to find, as you listen to our presenters from Santa Clara and San Diego, that we have represented here many of these models. I'm going to speak to you quickly about a fully integrated medical and mental health substance use model, and then move to the partnership model that is here on the screen right now. The fully integrated model is what we see principally in large quasi-integrated systems such as staff model HMOs, Kaiser in California being an example of that, where the facilities have all of the services, they share physical space, they share an electronic medical record. Another well-known example of a fully integrated medical and mental health substance use system is Cherokee Health Systems in Tennessee. Cherokee is both a community mental health center and a federally qualified health center. They have also recently added substance use services to their mix of services, and these are all fully integrated in the organization, in the facilities, in the staffing, and in the electronic medical record that they use. It's important to know that it took Cherokee 20 years to get to where they are, so getting that fully integrated is not something that happens overnight. Now, partnerships between community mental health and/or substance use organizations and primary care are the kind of model where primary care staff can be embedded in the community mental health or substance use organization, or vice versa. Mental health and substance use staff are embedded in the primary care organization. The advantage of these particular models is that the partners provides not only the staff member, but also the link back to the full range of expertise at their home agency via supervision, consultation, and referrals. The on-site clinicians can bill under the license of their home organization, which overcomes some of the financial obstacles that primary care sites face in providing mental health substance use services, and vice versa. And the challenges here include identifying partners that have the staffing and expertise to provide the care that's needed and is willing to engage in a partnership around successful collaboration. The linkage model, which should be coming up here on your screen shortly, is one in which primary care staff are not physically present in the mental health or substance use organization, but the mental health substance use organization conducts physical health screenings, coordinates very tight referrals to primary care, and shares information with primary care. Or alternatively, a very tight referral relationship where primary care refers individuals for mental health and substance use services. Ideally, a care manager in either of these organizations is following up to assure that the access is possible and that there is communication and coordination of services. The downside of this particular model is that it's only as successful as access to and quality of care across a range of community locations. It is, however, a starting point for a lot of agencies. They may begin with a tight referral relationship and then progress to a more developed partnership relationship. In working together to develop the partnership, one of the things that has been helpful to partners is to use the National Council's 4-quadrant integration model as a way of thinking through the population and how the population will be served, which quadrants will be served by which combinations of providers. For a detailed look at the 4-quadrant model, I would again refer you to the webinar that occurred on 5/6. The point of having it here is to think about it as a tool for a partnership conversation. Similarly, the care model, which is very well known in primary care circles as a model for thinking about organizing and delivering the key elements of a patient-centered medical home, is a very important model for partnering organizations to use to talk through how are we going to do the delivery system design of you bringing primary care to my mental health center, or how are you going to work through the decision support that you need if you're placing mental health or substance use staff in a primary care clinic. So both of these models give you a framework for a discussion to plan what you're going to do together. There is a new resource for partnership that has just been released by the National Council for Community Behavioral Health Care. It is a checklist of considerations for affiliation agreements between FQHCs and mental health providers. This is going to be available, I believe it was posted as of this morning at the National Council's website Resource Center, which is listed on the end of my slides when you pull them down from the CMH website. Finally, when we think about supporting partnerships, we want to build on the work that was done as a part of the Primary Care Mental Health and Substance Use Services Integration Policy Initiative. The vision that was adopted as a part of the IPI project, overall health and wellness, is embraced as a shared community responsibility. That really lays the groundwork for partnership work, a shared vision and an intent to work at the integration initiative using the 10 principles that are laid out in the IPI report and the Ipi Continuum, which also is a clinical framework for community dialogue. The Ipi Continuum has several components to it. It thinks about individuals who are mild mental health or substance use needs, moderate, serious, or severe. This happens to be a picture of the very first page of it, which describes the characteristics of the population. But you will find that the other aspects of the continuum are a description of the estimated size of the population needing mental health and substance use services, which you can apply to your local group, a healthcare home physical health services list, what needs to be made available, optimal mental health substance use services for each level, examples of evidence-based mental health substance use interventions, and some possible measures of process capacity or outcomes. At the same time that the IPI work was being done, there was a group of individuals who were convened by Neil Adams, at the time the Director of Special Projects for CIMH, and that group worked on the question of consensus guidelines. The guidelines that are the guideline product that has also been posted on the CIMH website speaks to the continuum of care, describes care settings, talks about clinical care guidelines, bidirectional transitions, and determining levels of care, and suggests several tools that might be useful for determining levels of care. The resources that you see here are the new Enhancing Continuum of Care Affiliations checklist that I just showed you, and the 2 healthcare home papers. All of these resources can be found on the National Council website.
Very good. Ms. Maurer, thank you so much for that wonderful presentation on partnership approaches. What we're now going to do is turn the floor over to Tiffany Ho and Bruce Copley from Santa Clara. And before we do that, we had just one quick question that came through. Ms. Maurer was referencing her earlier webinar that she provided as part of this series. That was presented on April 22nd. It is now available on the CIMH website. So if you missed it, please go to the website and check it out there. It was really excellent. With that, Dr. Ho, Mr. Coakley, the floor is yours.
Thank you. Hi, this is Tiffany Ho and Bruce from Santa Clara County. We would like to start by talking about our vision, and actually we base our vision of partnership between mental health department and our ambulatory care partner on the same vision that the IPI has, basically to achieve individual and population health and wellness, healthcare services for the whole person, to try and make it be integrated, planned, and provided through collaboration. So what we did, starting in about May of a year ago, was to sit down together and have the leadership of mental health and ambulatory care sit down and outline the collaboration between our 2 departments. I just want to point out also that we are also part of the whole Santa Clara Valley Health and Hospital system. So as such, we already have the same person that we report to, and all of our medical staff are already on the VMC, the Valley Medical Center medical staff, which makes things a little bit easier for us. Our program concept is that we want to, there are several FQHCs that are county-run in our county, and we wanted to select 3 of them that are geographically located in different areas of the county. One on the north side, one on the east side of San Jose, which is our largest population, and one in the south side, which is in Gilroy. We wanted the FQs to expand the services to include services provided by the social workers and the psychiatrist. Fortunately for us, some years ago, because of our history in working with the homeless population, Valley Medical Center had added in the behavioral health component to the FQHC rate. So once we decided that we were going to do this, we already had basically the case rate for the FQs. Our target populations are basically people who are mild, moderate, and severe. However, even the ones that have, well, I would say mild, moderate, and serious, these persons who have mental illness that do not require intensive case management. They could be referred through our traditional mental health department call center, or they could also be referred through the ambulatory care network from the primary care providers. We envision a tier approach where we would be providing 4 different levels of care. We could do a telephone, an email, or curbside consultation from the psychiatrist to the primary care providers. We could also have the social worker providing the telephone or email consultation. If necessary, we can provide face-to-face psychiatric consult and then also ongoing psychiatric treatment. All of the patients that are referred to us before they see a psychiatrist will get a full psychosocial assessment by a licensed clinical social workers. And all of our services, according to the rules of FQ, have to be face-to-face. From the Leadership and Management Authority, it was very clear to us that we have the content expertise on mental health services, and the Ambulatory Care Administration has a content expertise in terms of billing and compliance and issues having to do with FQHCs. So we decided that we would meet on a weekly basis to talk through all these things and to plan for them. You can see that we, the Mental Health Department, provide the oversight of the role and the outcomes of the mental health services to our staff. We set the tone, the directions, and the expectation of productivities and services. We are responsible for the day-to-day management of the clinic operations and the day-to-day supervision of mental health staff. AMC, or Ambulatory Managed Care, provide the integration of primary care with mental health services. While we're doing this, one of the primary care clinics, one of the ambulatory care clinic also roll out a new medical home model, which is a good opportunity to really talk about proactively plan comprehensive care for the patients. So we really rely on them to also encourage the primary care providers to screen for and think about referral to mental health. From a coding and billing standpoint, we developed a new billing slip for the psychiatrists and the social workers to do. We meet with the AMC, the ambulatory care staff, to look at their policies and procedure related to budgeting, accounting, reporting, documentation, coding, and billing, and work on them together. Prior to launching this, because we have a large number of staff now working together with ambulatory care, we had a large meeting where we invited various management staff from ambulatory care and our management staff to have a face-to-face meeting with our 8 psychiatrists and 19 social workers and our 3 managers to go over our expectations, to go over billing issues, medical records, anything that we can think of, and give them an opportunity to ask any hands-on questions that they may have. I'm going to pause for a minute here so we can catch up because our slide advancing is a little slow. So our next slide is on registration, record keeping, pharmacy, and labs. The nice thing is that we now have an integrated paper medical records because our staff who come from mental health are already used to typing their notes in our electronic health records. We carry that over and continue to have the progress note be typed. We actually have in the medical record 2 separate tabs for the mental health staff to file their notes, but now they're in the same medical record, so both the physical health care providers and the mental health care providers can see what's going on in the same record. The patient also have the same medical record numbers under registration, and also when they come, they also have the same financial screening so that we can determine what financial class they fall under. As you can see, our pharmacy and labs are conveniently located on the same site, which make things very easy. And actually these results, if the patients choose to go to our pharmacy and labs, are also available electronically on our desktop for both the primary care and the mental health doctors to see. The lessons learned from this experience as we see it is that we really needed to have more time to start up. We started in July and it's now May, so it's about 10 months. We have very ambitious financial goals, and it's mostly due to budget reduction pressure, and we really wanted to generate $10 million. However, we feel that's a bit ambitious. We also need to take into account the typical no-show rate and probably budget for about 20% of the $10 million to be no-shows. The most important thing that we want to emphasize for other folks who want to do this is basically the culture of mental health and primary care, and us kind of moving into this is different. Our staff, mostly case management, social work staff, and our patients have been used to an experience of a lot of phone work, a lot of case management work on the phone, home visits. And when we move to face-to-face appointments where we are expecting the patients to come in to see both the doctor, the primary care doctor, the psychiatrist, and perhaps also the social workers for several visits, the patients sometimes are not able to come in as regularly as we had hoped. So that really affects our productivity and our revenue generation. Also, another lesson learned in our partnership with primary care is that despite us having had several years of conversation with primary care where they have expressed a strong desire for access to behavioral health services, despite 10 months into the operation, we actually have only received about 150 referrals so far. We were thinking that they would be more in the order of 500 or so. So we have to look at other mechanisms to try and generate more patients for these 3 clinics. The same time that we are doing our integration, as I mentioned before, our primary care colleagues at one of the clinics is also learning a brand new way of working in medicine, which is basically moving from a traditional medical clinic to a medical home model where the patients could pick up the phone, call their provider directly at the clinics, and have same-day access to a nurse or a physician. So they have a lot of new work that they have to also learn at the same time. I think I mentioned before, but again, we feel that our collaboration is both a financial response, a budget cut, but also a strong desire to coordinate and integrate care. We are very mindful of our patient population, especially those with serious mental illness, are dying 20 to 30 years sooner than they should be, and we have been doing a lot of work in advance to prepare for access to primary care. So this is a really wonderful opportunity for us to partner together to do this and provide a holistic approach to care to our patients. Again, if we could do it over again, we would like to have more time for advanced planning and testing, etc.
So Tiffany,
this is Bruce Copley. The only thing I would add is for those that are on this webinar that are administrators, it's critical to understand the difference in the business model between our short Doyle programs that we're used to and working with an integrated medical system. We really need to rethink the business plan. We need to understand how we provide information to the consumer patient, as well as forge those relationships with the primary care physicians. Thank you.
Thank you very much, Dr. Ho and Mr. Copley. Before we move on to the San Diego presenters, Ms. Maurer, do you have any follow-up questions for the Santa Clara presenters?
I do have a couple of questions for them. Thanks very much, Bruce and Tiffany. That was great. I'm thinking about your last slide about the number of referrals you've received so far, and that leads me to think about a couple of questions. One of them is, physically, how are your clinicians located in the clinics? Are the social work staff embedded in the primary care teams, or is the behavioral health component in a separate part of the clinic physically?
In 2 of the 3 clinics, they are brand new buildings that were just built, so the mental health staff are located on 1 floor of the clinic, and the primary care providers are located on a separate floor, but they can easily walk up and down stairs to see one another. In another clinic, our largest clinic, the 2 clinics are right next door to each other.
But they are still kind of separate offices. Is that correct, Tiffany?
Correct. Uh-huh.
So here's a thought for you to maybe run a little pilot on, and that is if we think about some of the experiences that people have had in implementing integrated care, even having to walk up a set of stairs can make a lot of difference in terms of the way in which folks work together. And the most successful models actually have the behavioral health consultant clinician embedded in the primary care teams. So as you all have worked with your colleagues in talking about implementing medical homes, have you played at all with that model?
Yes, we have thought about it, and actually that's a request from the primary care doctors. We can really see the reasons why they would want that. And actually, when they ask for it, they actually think about the face-to-face psychiatric or social work visit, but they also thinking about the social workers doing resource development or case management or linkages, and also our psychiatrists providing consultation. When we talk about, we wanted to try and do it, but when we really talk to the nuts and bolts, we really want to try and generate 9 visits per day for the social workers, for example, and we felt that it was still a bit premature just to have them hanging out in the clinic and not necessarily having referrals right then and there. We're willing to explore it more, so we actually have a number of meetings with individual providers and talk about specific days that perhaps a social worker could shadow the primary care providers so that they can provide a warm handoff and introduce certain patients to the social workers.
That's a great idea. You know, the idea of trying a rapid cycle improvement of just doing it in a couple of practices with a couple of practitioners and seeing what difference it makes would teach you all a lot about how you may want to go in the future with that. My related question in terms of referrals is yes?
Ms. Mara, sorry, if you could hold that question for when we move on to San Diego as well. I'm afraid that we're out of I need to move on. Sorry.
Happy to do that.
Great. Thank you so much. Let's now turn to Marshall Lewis and Alfredo Aguirre for a brief overview of their work in San Diego.
Yeah, hi. First, let me ask, can you hear me?
Yes, we can hear
Marshall.
you.
Great, okay. Alfredo, after you.
All right. Yes, let me, I'll move the slides along. I want to talk a little bit about the background of our efforts with primary care, and Marshall's going to get more into the strategies we're employing and how this fits into the chronic care model, and we have a number of initiatives, and he's going to focus on, I believe, 3 of them. So let me just go back to the background. Our efforts started very early on. Let me see if I click and move this along here. Early with the community service and supports planning efforts under MHSA, we heard a lot from the community that that there was a unmet need, people who were not being served in terms of their behavioral health needs that were frequenting the community health clinic system. And so early on, and from my days from San Mateo, and actually Marshall brought a lot of good experience from Stanislaus, we felt it was important here in San Diego to do some effort with primary care to address, again, those individuals whose needs were not being met. Two specific strategies in doing this primary care interface was better access to care, of course, and also to really begin developing a model of interface within primary care. I use the word interface because that was a term I used in my prior county, and as work has evolved over the last few years, and with Marshall's leadership, we really have begun to push the envelope towards real integration. Anyway, we worked with a local, I would call them, technically they're not a federation, but they're in essence a consortium of community health clinics, federally qualified health clinics called the Council of Community Clinics in San Diego. We as part of our CSS plan, we developed a contract with them. The community health clinic system is comprised of 16 community clinic organizations that spread over 100 sites in San Diego, Imperial, and even into Riverside. This particular contract contracted with 9 clinic organizations to provide mental health services at 16 sites. And what I mean in terms of the subcontracts, these were those federally qualified health clinics that had behavioral health services. One of the models that we developed within the contract was basically replicating the evidence-based practice that came out of University of Washington and Jürgen Unitzer's model, the IMPACT program. And some of you are familiar with that, but just to briefly remind people, this is an evidence-based practice for the treatment of depression, which includes behavioral activation and problem-solving therapy provided by a depression care manager, and this is combined with meds management provided by the primary care provider. This has been actually quite successful in San Diego. Those that have engaged in this program, we've seen 50% of those clients that actually engaged in it actually had significant improvement in terms of their depression based on the PHQ-9 scale. The other thing that we really made a dent was improving basically access to care by Latinos. For the adult system, overall, we're about 16% of the adult system is utilized by Latinos, as opposed to the community, the effort we've done with community health, which is 50% of the clients served. And again, impact had a lot to do with it. One of the things we talk about is just the importance of really developing a strong partnership between us and the community health clinic side, but also our private contract providers in the regions throughout San Diego, because 80% of our system is contracted out. So we have a long history, legacy of excellent providers providing especially mental health care. And what we really encouraged the community health clinics and our community mental health providers was to develop a bond, a connection. And what we did, Marshall and I and other staff, county mental health administration staff, we did a tour of all the participating sites in this contract. And we wanted to get an idea of how it was going. They had been at least in place for about a year when we went out and did what we call the tour. And what we found was that in these various community health clinics, there were varying degrees of integration between behavioral health and primary care. What I mean by that is some clinics were a little bit ahead of the game in terms of employing the screening tool. The relationship between primary care providers in those sites and their behavioral health staff, remember they hired behavioral health staff, these community health clinics, varied. There was there was a lot more collaboration than others. Some it was pretty siloed. And then the other thing we looked at was what was their relationship with neighboring community mental health clinics. We had an example of a community health provider that literally was a parking lot across the street from a mental health contractor, and they very rarely talked to each other. So one of the things we did when we went around on this tour was to encourage, again, the importance of relationship building, that we knew that down the road when things would get tough financially around especially mental health care, that these relationships would be crucial in getting services, behavioral health services, to the indigent population. Again, I want to remind everyone that this effort we did with the Council Community Clinics was to serve the indigent population. As you know, as an FQHC, they do serve Medi-Cal beneficiaries in terms of behavioral health, independent of the county mental health system. And then I just want to, before I hand it over to Marshall, to speak a little bit to the vision of San Diego County. Basically, we are moving on a major initiative here in San Diego called the Health Strategy Agenda under Health and Human Services Agency. And this will be a 10-year plan that we're going to be bringing to the Board of Supervisors in July. We're actually running it by all the various boards and commissions that provide input into the overall health care and health and human service system to get their buy-in on this plan. It's going to cover three large domains: prevention, access, and care and treatment. Marshall has been one of the leaders in the effort in terms of really developing what this will look like. And bottom line, it's really about using, optimizing our resources to improve health outcomes for the residents of the County of San Diego. Barbara Maher already talked about the local models, and as you'll hear about more from Marshall, that our various strategies really touch on all those types of models: the fully integrated co-located model, the partnership model, which is shared across two organizations and with co-located staff, and then the coordinated care, or the linkage model. And just to be quite honest, we really did start more with coordinated care and then some efforts with partnership, and that has begun to evolve into a more fully integrated model. So what I'm going to do is have Marshall, you know what, I haven't been moving this, I just realized.
Okay, good. I'm sure you could.
Want to flip ahead? I guess we should have rehearsed, Alfredo. I think I have minus 3 minutes left. But
well, I was clicking, and it's
can I have 5 ladies?
No, here. Here you go.
Yeah, thanks.
Okay. Yeah, so we actually just have a couple of minutes. I don't know how much you can cover then. I'm sorry for the...
Okay, want to go ahead, Alfredo? Next slide.
Go ahead. I'm done. I'm trying to click onto your slide here. My apologies, Marshall. I wasn't I started clicking at the beginning. It didn't happen. Then I stopped clicking. I wasn't looking at the screen, obviously.
Okay, let me start talking while you, if you could get to the, okay, next. Let me just say that, first of all, since we have very limited time, one bottom line is that in talking with FQHCs, it's important to recognize that their concept of behavioral health integration, what they've been talking about separately in their silo for quite a while, is really treating clients who present with somatic complaints within the context of primary care. And one of the things we learned from our experience with the Council of Community Clinics is that we're talking about different populations. We're not talking about seriously mentally ill. Can somebody go to that horizontal line slide for just a...
Yeah, I'm getting there, Marshall. It's just,
okay. I think it's
really
fast.
slow when you click on it.
Well, let me just talk it through anyway. What we're talking about doing is partnerships along a continuum. Barbara already showed this, and clearly what we're doing is partnering with the community, and we feel like it's vital for the entire population. We're really talking about population management here, and we're talking about it in terms very similar to how primary care talks about population management, except the population that we've been focused on with diminishing resources, is the seriously mentally ill. Next slide. So we're talking about developing the concept of patient-centered medical homes as a system concept in which clients move smoothly between primary care and traditional mental health clinics depending on degree of acuity, and this is what you see right here. On the right side is primary care, the left side mental health clinics, biopsychosocial rehab, BPSR, and the primary care physician, the PCP, of course, is in the primary care side. As clients are more severe or acute, they would need more specialty services. As they're more in recovery or stability, they need more of the primary care services, focus on primary care. And throughout the client's move back and forth through the systems, we believe in the importance of community and peer supports. You see horizontal, or rather you see vertical dotted lines at 2 points. This represents, and this is really the key point to our message, this represents a permeable boundary between the two entities which will shift and move depending on the relative competence of the primary care clinic in treating uncomplicated or stable serious mental illness, and that in part depends on the resources available. So we have programs in which we have an embedded, as Barbara was suggesting, behavioral health consultant within the primary care team, or some that actually have, as you'll see below the horizontal line, within the FQHC, their own behavioral health program. Obviously, they can absorb appropriately a greater degree of severity, complexity of mental illness. The goal is that between the two, in developing this relationship, we will have better attention to comprehensive health care, including the physical health side. Part of on the left side of accommodating the patient population is having an embedded nursing care coordinator who is outstationed from the primary care team and becomes a full member of the mental health team as well. So that anywhere along this continuum, there's attention to the comprehensive needs of the client. But in general, we want to support primary care to develop increasing levels of competence and confidence and an increase in capacity to treat uncomplicated illness, so we can reserve our limited resources for the more serious, more complex needs of clients. Now, in talking with primary care, since the topic today is partnerships, it's important to realize that our situation is really very similar to the situation of other scarce specialties from the standpoint of primary care. They have difficulty getting neurological consultation, renal consultation for the safety net population, a variety of reasons, of economic as well as shortage reasons. So what we're doing is, as a quid pro quo for the shift of increasing numbers of our clients into primary care, is we are also requiring that there be support for primary care. And what this means is expedited, enhanced access to the mental health system when clients really need it, and access to psychiatric consultation on demand. So we really envision over time primary care developing an increasing competence level in dealing with uncomplicated illness because we are providing for them unprecedented access to our system when they really need it. In a sense, when we provide specialty mental health services, it's like they're treating in primary care a patient with a renal failure. The nephrologist isn't needed all the time. The nephrologist is needed if the person needs dialysis. So what I explained to primary care physicians is that in a sense, ultimately, our traditional mental health system will be like the renal dialysis for clients with serious mental illness. Next slide. Okay. So we have programs. The slide's not up yet, but I'll tell you, we have programs. We have programs along a continuum, ranging from programs in which there is collaboration, and we have a SAMHSA grant program. Many people know that we were very fortunate in being the only site in California to get one of the grants. I think there are 11 of them nationally. And it's a couple $1 million over 4 or 5 years. And in that program, we outplace a primary care nursing care coordinator in the behavioral health team to do care coordination. We have our Council of Community Clinics project that Alfredo described, which is the administrative lead on the contract. Next slide, please. So there you have a case of collaboration, a little outplacement and integration of physical health through the care coordinator, the nursing care coordinator being outplaced from primary care in the mental health setting, but it's on one end of our integration spectrum. In the middle,
I'm afraid we're about out of time. If you could wrap up.
Okay. At any rate, we have programs across the spectrum. The other end of the spectrum, we have a rural health initiative in which we have cross-placement of nursing care coordinators and behavioral health consultants in the other's turf. We have anti-stigma training. We have cross-referral and support relationships all worked out. We also have an innovations project which adds a component under MHSA, which adds a component of a shared alcohol and drug specialist. So lessons learned. Structure is everything. We're a little vague in some of our contracting to start with, and as I mentioned before, people were speaking different languages. Primary care approaches the idea of integration thinking about a different population. We've learned that we need to be extremely clear in contracting in our statements of work about what the end product is that we want. We need to respect the fact that aside from the financing issues, there is a huge cultural divide. We have a summit coming up where we're going to have leadership of primary care, mental health, and ADS, alcohol and drugs, come together to talk about how their work style is different, their access points are different, their traditions are different. So we need to be very respectful of different cultures. And the last point, again, is to be very explicit in the contracting because you have to, from the get-go, have the right structure and have in mind a clear vision of the kind of integration you want. Okay, sorry to have to rush through it. Thanks.
Great. Thank you very much, Dr. Lewis and Mr. Aguirre. What we're going to do now is turn to some questions that Ms. Maurer has specifically for San Diego, and then she was going to facilitate a mini dialogue with both Santa Clara and San Diego before we get into audience questions. Ms. Maurer, if you could just take about 10 minutes and maybe start off with a question for San Diego, but I think then we can just move on into whatever questions you have for both set of panelists.
Okay, thanks very much, Lori. Marshall, Alfredo, one of the things that's fascinating about San Diego is the variety of models that you have in play down there. And that makes me wonder about a question that Bruce and Tiffany addressed clearly, and that is how they do it, how they manage record keeping and information sharing, because they're all a part of one system. How is the question of information sharing and charting being handled in these various types of partnerships that you have in San Diego?
We have in general, we have releases that clients need to sign in order to release information. It would really be like more distant consulting relationships, but that, for the time being, is what we're having to work with. We do have plans, and we're beginning to put some seed funding into a shared master patient index system where we'll be able to start looking at data together. But that is one of the obstacles we face because, as Alfredo pointed out, we have a network of dozens of primary care clinics.
And you also have a network of community-based mental health providers. So at this point, everyone essentially charts in their own record, but then has information sharing on the basis of client releases. Is that correct?
On the mental health side, we do have Anasazi, which we are in the process of implementing. So on the mental health side, we have a uniform medical record that we're implementing, as I say, as we speak. Many parts of it are already implemented, and it's going fairly well. So the interface becomes a little simpler because wherever the client is in the mental health system, it's a matter of that system being able to interface with what will hopefully be a kind of health information exchange of the primary care clinics.
Okay, okay. Another thing I'm curious about, again, given the multiple kinds of partnerships that you have in play, we heard from Santa Clara about the kind of meeting structures that they've put in place in order to do regular ongoing problem solving. Talk to us a little bit about how you're handling that in San Diego.
We are, from the top down, fostering meetings, and essentially it's a kind of a naturalistic process, and that's what the horizontal line diagram is meant to suggest. People are all at a different place. All of this integration is, I believe, has to be extremely local, depending on the needs and the interests of the individuals involved. So we have not come up with a formal uniform structure. I was very interested, Barbara, in the document from the council, which organizes better than we have, or farther than we've gone in our work, the kinds of agreements that you might want to solidify between the respective clinics. But essentially, we've promoted the relationship, talked about the outcomes and the vision, and then so far we've been more or less leaving it to the players to work out the details with our input. But I think as we learn more, we're going to be much more concrete.
Okay.
Yeah, and Barbara,
Alfredo, did you want to add to that?
Yeah, I just want to say that Marshall kind of alluded to it, but in every region, what we're seeing, which is very positive, is the pairing of community mental health provider agencies and federally qualified health clinics. They're basically developing a partnership and having ongoing meetings to work on actual protocols for referrals, troubleshooting when someone is referred, but the feeling is the person is not ready to be seen in the federally qualified health clinic setting by a primary care provider. We're trying to encourage those relationships as opposed to imposing, the do's and don'ts and how they relate. So thankfully, we have a very proactive community in the regions. As Marshall said, this reform is really happening locally, pretty much region by region.
And part of this reflects the culture of San Diego, because San Diego is very conservative and has very much relied on individual initiative.
So I think the takeaway for our listeners, both from your comments and from the Santa Clara experience, is that while there's no single model for doing this, it's necessary to spend a lot of time talking to get these projects off the ground and to keep them going smoothly. Would that be an accurate statement?
Yes, definitely. Because there's so many cultural differences that have to be overcome.
Okay.
Yeah, Marshall, by the way, is meeting with the medical directors as well of all the clinics. That's been really positive.
Oh, okay. So both primary care and mental health clinic medical directors meet together?
Not yet. But
okay.
I've been the go-between. I have ongoing meetings with both groups.
I see. Okay. So let me ask a question to both teams at this point, and that is, you've talked about lessons learned. Let me phrase the question slightly differently. If you had it all to do over again, what is the single most important thing you would do differently?
Well, for Santa Clara County, we would have had a much more conservative approach on revenue. In terms of the actual implementation, I think it was all part of a budget process. So from June 30th to July 1, we transitioned 3 of our clinics over to FQHC, which actually went pretty smoothly. But I think the anticipated revenue has put the most bind in terms of us having time to look at the models and refine the models rather than really being concerned about the amount of patient care that we're providing by our clinicians and our doctors.
For San Diego, I'll let Alfredo give his perspective, but from my perspective, I got here 2.5 years ago, and the council contract was already in existence. And frankly, we've been fiscally very, very responsible and conservative and cautious, because that's the culture in San Diego. And I think that things have evolved very well, because we began with relationship building around a contract that didn't fulfill all of our needs, but got people talking and got us familiar with all the players in the primary care environment. So I think that the idea of an evolving process of strengthening relationships and developing structure that reflects the needs of the entities really makes a lot of sense. So I can't think of anything specific. Can you, Alfredo?
Yeah, two things I'd like to mention. One is I think it was alluded to earlier when Marshall mentioned lessons learned, and that is what we didn't put in the contract initially was some specific expectations of employing the screening tool. Believe it or not, initially we didn't provide for collateral visits. We did build that in. We didn't put in the statement of work that the community health clinic should be talking to providers, community mental health providers. So we built those in over time, as Marshall talked about. It really did evolve. The other big issue, for those of you interested in children's pediatric integration with behavioral health, was that program really never took off because we had so many efforts that were school-based, efforts through child welfare, and we haven't received very many referrals of children, partly having to do with the children typically are Medi-Cal eligible, even if they're children of parents who are undocumented. If they were born here, they have Medi-Cal eligibility. And those that are indigent, there's the issue of enrolling them in mental health care, which is prohibited here in San Diego for ongoing outpatient care. So there's an issue there around being documented or not. We actually are kind of getting around that somewhat with our rural effort, which is a prevention and early intervention effort where we can do some screening and early intervention and work more with the broader population because it's not a treatment-focused program necessarily. So, but lessons learned is I think I would have done more work around the needs of the pediatric community and perhaps looked at a different model.
Okay, thanks. So, Lori, why don't we go? I've got a couple more questions, but let's see what you've got coming in from our listeners and take some of those questions next.
Sure thing. There are a couple of quick questions. One for you, Barbara. Is there or will there be a directory of ACOs? Can mental health providers approach ACOs to develop partnerships?
You know, that's a great question, and the answer, I think at this point, is it depends, which is that this is going to roll out state by state. How ACOs develop is going to be not unrelated to some of the rest of the questions about what states will do under healthcare reform. And, you know, there's a number of things that states will need to decide how they're going to structure the exchanges for health plans. And I know there's already a bill pending in your legislature to move forward on the creation of a health plan exchange. How are they going to deal with high-risk pools? And another one is how will ACOs be organized and acknowledged for payment purposes. I think in California what we're aware of is that right now it's more the private and commercial plans that are driving some of the consolidations and creations, getting ready to create ACOs. So the best answer I can give you is that you really need to start talking to the healthcare community in your county, the your public hospital if you have one, the other hospitals. You need to understand what people are beginning to consider in terms of new kinds of associations and build that knowledge from the ground up. I think we do know that, and we keep saying this, all healthcare is local, and that's going to be true for ACOs as well.
Great. Thank you very much. The next question is for the Santa Clara folks. It was in reference to your presentation. They wanted to know, what is the rationale for excluding patients who need intensive case management from the program?
Well, we had an interesting collaboration. In the FQHC programs, we have retained some case management on the short Doyle side, so individuals that need the more intensive case management can still receive those services from the department, though they are seeing their doctor at the FQHC. Or if they're in very intensive needs, we will refer them back to our short Doyle program. There's not a wait list. We actually can do it within 2 weeks if we believe they are better served within the traditional rehab option model.
Great. Thank you very much. The next question really, it sounds like, goes to any of you all. The question is this. A major challenge we face in our area is forming a reasonable working relationship with our area FQHCs. What advice do you have for CMHCs and FQs for how to lure one another to the negotiation table?
I can jump in just real quickly. One of the things I think we have to do as mental health professionals out from the county mental health system is to watch our sense of, I don't know, arrogance is too strong of a word, but I think we can't impose a sense that we know what's best for clients with multiple needs. And some of our terminology that's recovery based in the physical healthcare world, they have different words, different jargon like disease management, but it's all very focused on client empowerment. We might call it client-centered care. They call it something else. I just think we just need to be very respectful of those cultures and also respectful that the community health system has done a lot. For example, the area of cultural competence. They really have developed the Promotota model way before community mental health did. And sometimes I think we can come across like we know everything. I just think we need to be respectful of cultures, and it goes the other way too. Obviously, helping the physical healthcare world understand our clients who we've worked with, people with serious mental illness, and helping to bust down stigma and discrimination that may occur in a waiting room, for example. So again, it's about mutual respect.
And as far as specific inducements go, I think that there needs to be a quid pro quo so that everybody gets something out of it. In our particular model, primary care gets improved access and improved consultative support. And on the mental health side can be induced by the access both for their current clients and potentially for stable clients who may be referred over. So I think there's clearly something in it for everybody to do much better care coordination and cross-consultation.
This is Barbara. I'd like to piggyback on Marshall's observation. I think one of the keys to it is really to come into the conversation with a focus on populations and being able to talk about all of the populations in a community that need service and figuring out together how you can best collaborate to meet the needs of those populations. If you only come to the conversation thinking about one specific group and that's all you want to talk about, it's not going to be a very successful conversation.
That's a very good point, and we found that the leadership of the FQHCs are very passionately committed to the populations they serve. It's quite astounding. You have extremely talented CEOs of these organizations who would be making much more if they were working for hospitals or private healthcare concerns, and they work tooth and nail for their communities. So I think that Barbara's approach is right on, that if you sit down and talk about how can we together work to serve the needs of your community better, it gets a lot of traction.
Great, thank you. The next question is this. We're a community health center, and we're looking at bringing mental health services into our site. Can any of you talk about the pros and cons of contracting with a CMHC for those services versus hiring our own mental health providers?
Well, if you hire your own mental health providers, you have the cash flow. You can provide. It's easier to provide coordination of care. You'll have the same medical record, for instance. So there are a lot of pluses to bring as much as you can in-house.
I think, this is Tiffany, I think the best of both worlds when you're going to hire your own people is to still develop a partnership with specialty mental health, because there's always going to be some patients that are going to need a higher level of services than your average provider in the FQ would be able to provide, whether it's hospitalization or urgent mental health services or intensive case management. So ideally, I think you should look at your level of needs and then decide accordingly.
Any other responses to that from the panelists?
Well, I do think there is I mean, obviously with MHSA, there was a new set of revenues to provide services to the population that were either underserved or unserved in our communities. And, you know, for community health to really develop a behavioral health initiative with the indigent population, as you know, they kind of scrape by with whatever dollars they can raise, but it's obviously not very robust. Obviously, this provides an opportunity to serve the indigent population and in a community health environment. So I think there was an opportunity here, you know, but with that comes having to contract with the county, and we can be tough, particularly in San Diego. We do a lot of monitoring. We can make it tough for contractors. But as Marshall talked about over the years, I think we've forged a much more a better partnership with the council, and I think we understand each other much better. But it was tough, to be quite honest, because those clinics were not used to contracting with county mental health. But it was worth it.
Thank you all. The next question is this. We're partnering with our local community mental health center to do mental health services in primary care. And we have a mental health provider on site now 2 days a week. We thought we'd have a huge response from the primary care providers referring patients to the mental health person, but her caseload is still really, really light. The partnership is not going well. Any thoughts?
Yeah, this is part of the culture of primary care, I think. You know, and ever since the switch was thrown for managed care, primary care tends to get it, just like all of us, in a certain rut. If they don't have ongoing consultation available and ongoing resources, mental health resources, they're simply not used to thinking in those terms. I think that it's really incumbent on the providers to be doing outreach, cross-outreach, and to think about the other side as the customer, to try to work with the customer to figure out what service really adds value to them.
This is Barbara. Let me tag on to that with a couple of thoughts. One of them is this is the time to really back up and say, what's our clinical model of service delivery here? Because there are tons of examples of a mental health center putting somebody into a primary care clinic who intends to and only has the the information to do what they've always done, to do services the way they've always done them. Most of those partnerships fail because the practice in primary care is very, very different than the practice in a collaborative way in a primary care setting. So my advice would be that you need to take a step back and take a look at what's our clinical model of care. And again, I'll reference the webinar that we did earlier. Lori, thank you very much for clarifying that it was in April. Time flies. I was just saying May 6th. That's today, right? So the April 22nd webinar, one of the things that I talked about was workflows, 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 which is what's your clinical design and how does your workflow support that? And make sure that you are delivering services the way you together agree they will be delivered. A key piece of this is a question about screening and implementing universal screening in the primary care setting, because that's the way that you can begin to identify people who aren't rising to the level of, you know, horns blowing, lights flashing, this has got to be a referral to the behavioral health consultant, but you will begin to identify people who have moderate to serious depression, for example, or anxiety that simply have not yet delivered that message clearly in the primary care setting, and you can begin to serve them.
Great, thank you. And Barbara, just so you know, we had a question about the Ipi report, the Integration Policy Initiative report, and so if we can include a link for that, that would be helpful on the website.
The Ipi report is on the Cmhc website right now. It actually has 3 volumes to it, and all 3 volumes can be accessed if you go to the Cmhc website and go to the drop-down menu that I believe is special projects. You will find the integration site there and all of the materials on that site.
Great, thank you. So we're running a little short on time, so I have another question I'm going to combine for you all. These questions about releases of information and confidentiality. So if you all could just talk about how you do releases of information when there's the separate behavioral health and primary care providers. So do you have them sign releases on both sides, and what do you do when the patient refuses to sign them? And then secondly, how do you deal with confidentiality when you have 2 different records in the chart? And that's mental health and general health in terms of what can be shared and to whom. So I know those are big questions. We have just a couple minutes. If anybody could kind of talk real succinctly about those issues.
Marshall, maybe you spoke about the release of information process in San Diego. Can you talk a little bit more about it? Is it a standard release that's being used on both sides?
Yeah, it's various releases have been adapted and that are site-specific and meet the relevant attorney's approval. You know, the issue of the release is always an important clinical issue. Of course, there's the ability, despite lack of release, to communicate among providers for the sake of providing ongoing health care. So you can get around it if you really have to, because we're permitted to do that as providers. It becomes a clinical issue, particularly on the mental health side. How can the client allow you to help them unless you know, they're giving you adequate permission so that you can act in their best interests and coordinate things. So I don't think there are any special problems. For the most part, our experience has been, I was just getting filled in yesterday on the status of our SAMHSA project, for instance. For the most part, the experience has been that clients are fine about sharing. We have also involved our recovery community, by the way, and they are very supportive of efforts toward integration, and they believe very strongly. We have RICA of California, which is a branch of you know, Lori Ashcroft's program in Arizona. They are actually very supportive.
interrupt you. I'm sorry, I'm going to need to interrupt you. I'm so sorry, but I just got a note that we're actually going to be cut off in 1 minute. I didn't realize that the webinar was going to do that, so I'm very sorry to have to interrupt you. We will post questions on the website. I'm afraid we're out of time. Please visit the CIMH website for this, this webinar, the materials, the FAQs. If you wish to register for future webinars, you will see links for how to do that on your screen. Our next webinar is on May 13th, and we'll focus on addressing substance use issues in primary care, expert and emerging opportunities. I'd like to thank all of our presenters very much for sticking with us and dealing with the logistics, and to all of you for joining us. Thank you very much, and have a great afternoon.
Thank you.
Thanks.